So welcome everyone to the training on the Ages and Stages Questionnaire 3 and the Ages and Stages Questionnaire Social Emotional. My name is Chaya Kulkarni and I'm the Director of Infant Mental Health Promotion at the Hospital for Sick Children. So during this session, we are going to be looking at the benefits of developmental screening. I'm going to describe the features of both tools, but we will start with the Ages and Stages Questionnaire 3, which I'll refer to as the ASQ3 from now on. I'm going to show you how to actually screen the ASQ3, how to describe the ASQ3 cutoff scores, how to interpret the ASQ3 information in relation to other referral considerations and other information that you might have gathered. We're going to then talk about the importance of sensitively communicating the screening results, the process for making referrals to appropriate agencies for children, also look at appropriate follow-up activities, and then talk about options for using the ASQ3 in other settings such as with child care staff as well. So part of the reason that we are so excited to see the ASQ, or a really good developmental screening tool, embedded in the AAR process now is because we have a much better understanding of just how significant the first 3 years are in a child's life. And what's become very clear and is supported by a very strong body of evidence now is that there are many parts of development in the brain that are happening that actually peak in the first 3 years of life. And that these parts are most easily influenced, both positively and negatively, during this period. And that whatever influence takes place will shape the architecture of the brain and will actually influence a child's outcomes both in terms of physical health as well as mental health much later into their adult years. So just let's click a couple of times on this slide so that we can look at what happens with different trajectories. So the one more time, yeah. So the dotted red line is the developmental trajectory of a child who is in an optimal home environment, where there's responsive caregiving, appropriate types of discipline, parents are probably spending one-on-one time with the child, etc. The solid black line underneath is the developmental trajectory of a child who is in a far less optimal home where there isn't consistent responsive caregiving, where parents or caregivers are not spending quality one-on-one time with a child, where there may not be appropriate disciplinary methods being used. And what you see is that very early on, in fact, even before 6 months, we start to see a gap in that, in terms of the trajectory. And you can see that the child in the less optimal home has a much lower developmental trajectory. So if you fast forward even a few years, sorry, that's okay. What we know is that children in that who are seeing that lower trajectory are going to be starting school already behind their peers. And the challenge really is, how are they going to catch up? Because the greatest period of plasticity has in fact already been experienced. And while plasticity, or the brain's ability to still change, continues for many years, it will now require more resources, more effort by everybody, including the child. So by doing some screening, what we're really hoping to do is get ahead of that trajectory and really start working very early on to get that child's trajectory looking more like the dotted red line. So what is the ASQ3? Oh dear. Okay. So this is a parent or caregiver completed screening tool. It encourages involvement of caregivers. It includes a series of questionnaires for children ages 1 month to 5.5 years, and it accurately identifies children who may be at risk for a developmental delay. The domains that we're going to look at when we go through the ASQ3 include communication, gross motor, fine motor, problem solving, and personal social. Once we complete the ASQ3, we're going to look at the second tool called the Ages and Stages Questionnaire Social Emotional, which focuses strictly on social emotional development. So a little bit of background information about the tool. It was initiated in 1980 at the University of Oregon. The authors had looked at a number of standardized tests as well as literature and selected items that were easily observed or elicited by parents or caregivers in a home setting. They published the ASQ3 in the mid-2009. The ASQ-SE was published in 1995 initially, or initiated in 95 and published in 2001, and it actually has undergone a review and has been redeveloped in 2015. But for the purposes of the AAR, we will be using the ASQ-SE that was developed in 2001. Okay, so let's look at the different types of assessments that you or other clinicians might be engaged in as you try to support these very young children who may be involved with your agency. So you may be doing screening assessments. Diagnostic assessments are typically not done by social workers or child and youth workers, but are typically done by physicians or psychologists or licensed psychometrists. And then the third type is a curriculum-based or programmatic assessment, also can be called a functional assessment. Screen. So when we look at the first one, which was screening assessment, this is really a very brief procedure that's meant to identify those kids who should in fact be receiving more intensive diagnostic or evaluative assessments from a different kind of professional. And these are kids who typically may actually require early intervention services or special education services of some sort. In comparison, a diagnostic or professional assessment is much more in-depth. It often just looks at one or more developmental areas to understand the nature and extent of a physical developmental problem and to determine if a child's eligible for services. So what's important here is that while diagnostic assessments have largely focused on physical, there is gradually a movement to include early mental health diagnosis. We see kids who have attachment disorders, feeding disorders quite early on that we now actually are able to diagnose, and that can be done by the appropriate professional. And then the last type of assessment is a curriculum-based assessment. And this is ongoing. It's also quite in-depth. And from a programming perspective, it really helps, for instance, an early childhood educator determine a child's current level of functioning and what would be appropriate in terms of next steps, next goals. So it provides a useful child profile. It helps with program planning, helps identify goals and objectives, and it can be used to evaluate a child's progress over time. So we're going to focus on screening, and that is what the ASQ3 is designed to do. So this is what it ideally looks like. You would take any population of children, and you would complete the ASQ3. For those children whose scores were above the cutoff, you're going to go and you're going to let them continue as they are. Hopefully they're in environments that are supporting their development, and maybe you're going to make a decision to check in again a year from now because there's no evidence of a delay or a risk of delay. But for kids whose scores are actually below the cutoff, this is when we're worried. This is when we need to look at making additional referrals for further assessment. And that may be to a developmental pediatrician, it may be to a psychologist or a psychiatrist. It really does depend on the nature of the delay that you've identified with the tool. And then in the middle of those two, we have kids who are near the cutoff, also referred to, and as you look at the tool later in the presentation, you'll see it's sort of a gray area on the summary page, and we call this the monitoring zone. And this is when kids score above the cutoff, but their score is actually still very close to the cutoff. So we feel that there's a need to actually monitor that child more regularly, make a decision about whether you want to make a referral now, even though they're not below the cutoff. You're concerned enough that you feel that making the referral would be a very proactive step to take. The one thing I will encourage you to do for those kids who are near the cutoff, I would encourage you to err on the side of caution and make the referral, just knowing that in many communities across the province, we have extensive waiting lists. And so you want to get the clock ticking in terms of that waiting list. So I would encourage you to make the referral for kids who are in that monitoring zone. Okay. Monitoring is also a form of developmental screening, and it happens at frequent intervals for young children who are at risk of a delay. And for kids who are involved in child protection and for that very young population, monitoring should actually be occurring while they're in care and not just once a year. So while the AAR will be completed once a year and you'll automatically be doing the ASQ3 and the ASQSD, for those kids who have scores that are concerning, the scores that are below the cutoff or in that monitoring zone, you actually want to go in and rescreen them again every few months. You really want to stay on top of where they are developmentally. In terms of the incidence of kids identified as having a disability by age, we see the smallest number identified in infancy, and you can see by the time they get to preschool, the number has increased quite significantly. And just to put a framework around the difference between looking at a child with a tool versus looking at a child without a screening tool, the chart that you're looking at clearly shows or illustrates that when we actually use a screening tool, we identify more children who may be at risk for developmental delay, but we also identify more children who are at risk for mental health problems. And we really can pick these up as early as 1 month in a child's infancy. Okay. So let's look now at the features of the Ages and Stages Questionnaire 3. So first off, there are 21 questionnaire intervals, and you can see them listed there. In the first 2 years, the intervals are very tight. So you've got 2, 4, 6, et cetera, all the way up to 24 months. For the older kids, the toddler years, the intervals are a little bit wider, and by the time they get into the preschool years, the questionnaires are spaced 6 months apart. Okay. Now, this is going to be very important for you when you're choosing what age questionnaire you need to be looking at. So on the front of your, or at the top of your ASQ, or where the ASQ begins in the AAR, it's going to show you the ages that that questionnaire can be used for. And it's important to look not just at the bold number, in this case it's 16-month questionnaire, but you'll notice just above it, it indicates that that 16-month questionnaire can be used for children 15 months and 0 days old, right up to 16 months and 30 days. So the 16-month questionnaire actually has a 3-month window in terms of the ages that it can be used for. Okay. In terms of the cover page, or on the top of your AAR, you will capture this kind of information in terms of the child's name, any kind of identifier, the date that you're actually completing the AFQ, the date of the child's birth, and you're going to have to think about prematurity as well, because if the child was premature, you will have to calculate a prematurity age, and you can actually go onto the AFQ website, and there is a calculator there that will calculate that age for you. So there's 5 developmental areas, which I identified earlier. Each of the areas has 6 questions, and these questions are hierarchical in order, so they go from the easiest task to the most difficult task. But you need to keep in mind that the last 2 questions, so questions 5 and 6 in each of the domains, are average skills for children of that age, right? So some people will want to identify, based on the AFQ3 results, an area of strength for children. You really can't do that, because even if a child has scored perfect in any domain, all that tells you is that they are meeting the average skills for a child of that age. So it can't be considered a strength. It also means that if you're doing the screen on a child, and as soon as you get to the 3rd question or the 4th question, and you're seeing that they can't actually complete the task, aren't able to, right then you know that, okay, we've more than likely got a risk of delay in this particular domain. When parents are completing the forms, or when you are completing the forms, you have 3 options in terms of your answers. You can answer yes, sometimes, or not yet. And the forms are written to a grade 4 or 5 reading level. Some of the other features: once you've completed the scored section of the AFQ3, there are a number of questions that are unscored. And these questions look at skills, for example, speech and articulation. The example I've given here is, does your baby use both hands equally well? Because we know that if an infant is not using both hands equally well, we need to really probe some more, connect with a physician, because there may be a risk of something such as cerebral palsy that may be at play. If you are doing the AAR in this portion of it with a foster parent or biological parent or kin or kith, one of the things you also want to be aware of in this section is that they may raise concerns that have not shown up in any of the questions that have been asked on the ASQ, because there is a section for them to put any other concerns they may have or declare any other concerns, or you may want to add something in that section. It is really important that you pay attention to that, because we now know from the research that concerns raised by caregivers are in fact quite predictive. So even though it may not have shown up in the ASQ, you don't want to dismiss the concern that the caregiver may have raised for you. And any answers that show up as concerns or questionable responses that you have, if you're doing it with a caregiver, you really want to go back and follow up on those. Okay. In terms of the overall section, so this is not a scored section, but it will look at early language, behavior concerns, and articulation concerns. And you can access the user guide. I believe OACS can direct you if you need to access the user guide that gives you a little bit more information on those overall questions. And then finally, at the end of the ASQ, what you're going to find is a summary sheet. And the summary sheet is broken up into 5 different sections. So there's a child and family information section that gives the child's background. There's a bar graph with cutoffs, and that bar graph is really very important, because that may be the piece that you look at to understand where this child is at very quickly. an overall section where you transfer your overall responses, and then any follow-up action to be taken. And there's also a way for you to transfer all of your individual scores into a little box if you wanted to, but it's certainly not essential. Okay. So I'm not going to go into much of the research on the tool, but I did want you to take a look at this particular bell curve, which is the bell curve for the ASQ3. And so remembering back to what I talked about, questions 5 and 6 are average skills that 68% of the population can actually master. They can do it when the screen is used. And then when we see kids who are just one standard deviation below that 68%, they're in the monitoring zone. And when they're 2 standard deviations below, they're actually clearly below the cutoff, and there's a risk of delay. In terms of cultural adaptability of this tool or of the questions, there are alternative administration methods for individuals from different cultural backgrounds. You can definitely, if you're doing this in partnership with a foster parent or a biological parent, you can do this with translators. They typically actually do like it because it is very clear. You can also look at using alternative materials for individuals from different cultural backgrounds. The normative sample was based on a very diverse population, and the scoring actually permits you to omit inappropriate items. And that's something that I actually do like, because sometimes for cultural reasons or because of a child's social history, there may be a task that really would just not be appropriate for that child to be doing, and you just don't even, you're not going to get an answer about whether he can or can't do it because he's never given the opportunity, and you want to be able to omit those kinds of questions. So moving on and looking at the pre-screening activities that you want to be doing. So make sure whatever consents need to be obtained are obtained. If you are doing it with a caregiver, make sure that you explain the whole process of screening and review the questionnaire content. You're going to schedule time to do the screen, and even if you're not doing it with a caregiver but you're doing it just yourself completing the screen, you may want to actually have the child do some of the activities or tasks. So you want to make sure you've got the appropriate materials available in order to do that. Okay? In terms of choosing the correct ASQ3 form when there is a child who's premature, it's a pretty straightforward calculation. I'm going to walk you through it very quickly, but also encourage you to go onto the ASQ3 website, and there's a calculator there. Essentially, you would only do this for children up to the age of 24 months. After that, the prematurity does not really matter. It's not relevant. So for a child who is premature and younger than 24 months, you're going to subtract the weeks of prematurity from the child's age at the time that you're administering the ASQ. And then you're going to use that as the adjusted age to choose the appropriate ASQ 3 questionnaire. We don't typically in Canada use a corrected date of birth. I'm not going to review that, but if you need to, again, you can go onto the ASQ website, and there is a calculator for that. So let's move on now and look at the different scoring steps. If you could just click. So step 1, and there's 5 steps altogether. Step 1 is that you're going to review the responses. So if you've completed the ASQ3 or you've completed it with someone and there may have been items that either you didn't answer or the person you're doing it with didn't answer, you actually want to go back to those items. And you want to make sure that you actually can't get an answer before you decide to omit the question. Step 2 is you're going to calculate the area totals. So here's what the scoring looks like. A yes is equal to 10 points. A sometimes is equal to 5 points. And a not yet is equal to 0. If any items are omitted, you're going to calculate a new area total, which I'm going to talk about on the next slide. Step 4, you're going to review the overall section responses and ask for any clarification if you've been doing this with a caregiver. And then step 5, finally, you're going to transfer everything to a summary page. So let's look at how to deal with omitted items. So first of all, you can omit up to 2 items per domain. So you can omit 2 items in communication, another 2 in gross motor, another 2 in personal social, etc. If you need to omit 3 items, there's no point in completing the tool. It's no longer valid if you've had to omit 3 items. So what you're going to do to get your adjusted score or a new score is you're going to divide the total area score, which you already calculated. You're going to divide it by the number of questions in that domain that the caregiver or you answered, and you're going to add that amount, that answer, to your original score. So if the original area score was 45, and whoever was filling out the questionnaire answered 5 of the 6 questions, you're going to divide 45 by 5, which gives you 9. And then you're going to add 9 points to the 45 points you already had, and that gives you a new area total of 54 points. Okay. So in terms of interpretation and recommendations for follow-up, just some things for you to follow up and determine follow-up activities or actions. You want to look at the total ASQ area scores. You want to think about the overall responses, and then any other additional considerations. And this is actually very, very important when we're talking about infants and toddlers. People often forget to look fully at an infant's social history or a toddler's social history. But we know that for those young children who have experienced a lot of disruptions, a lot of placements, these kids have actually experienced trauma. And you want to be factoring that into your formulation of a plan in terms of next steps. Other considerations, biological factors, health factors that may be at play. For instance, the day that you went to observe the child to complete this section of the AAR, the child, was suffering from a very bad cold or the flu. May not be the best day to actually try and do this. So take things like that into consideration. Family and cultural context, stressful events the child has experienced, caregiving environments. And just to really be quite emphatic about this, for young children who you will be using this on, who have been in care for a year or longer, their life has been full of stressful events. And those stressful events for those very young children are actually very traumatizing. The challenge is that they can't tell you that. They don't have the language skills to tell you what those experiences have done to them. So what we have to do is really look carefully at their development, because that's where we really start to see the impact. So thinking about and gathering that family and cultural context is actually a very important part of this process. And then environmental factors, does the child actually have an opportunity to practice the various things that we're expecting him or her to do? So, for instance, if you're expecting this child to play cooperatively with another child, but this child is actually never in the presence of other children, then you've got to adjust the environment and see how to give the child an opportunity to actually practice that. Then looking at developmental history, did anybody else complete a screen? What did they learn about this child? So looking at that as well. How much contact is this child having with you, with other caregivers? And what are the resources that are going to be available for this child? In terms of follow-up or referral, so if the child is above the monitoring zone, you can just provide some follow-up activities and rescreen in 6 to 12 months, because above the cutoff indicates that there isn't a risk of delay at this point in time. If the child's score is between 1 to 2 standard deviations below the average, and they're in that monitoring zone, you want to make sure that you provide follow-up activities to practice specific skills, especially because we know that if you make a referral, there's going to be a wait time. And the way a baby's brain develops, good or bad inputs, it keeps developing. So as much as possible, try to give caregivers some activities that they can begin to use to help that child work on the skills that have been identified as concerning, or the areas of domain, or the domains that have been identified as potentially at risk for a delay. You want to rescreen, and I apologize, there is a typo there, not in 2 hours, but in 2 months or 6 months. And you're going to use your professional judgment to decide how soon you're going to do that rescreening, and then you're going to make the appropriate community referrals. For kids whose scores are clearly below the cutoff in 1 or more areas, you're going to want to make referrals for further assessment, and you are definitely going to want to rescreen at least in 6 months. In some cases, you may even rescreen earlier if you're seeing a lot of delays, a lot of concerns. You really want to keep track of whether this child's development is continuing to deteriorate or whether there's somewhat of an improvement, which could be attributed to anything from being in a really responsive foster care home or attending a high-quality child care program. Could be any number of things. You also want to make sure that if there were concerns raised by caregivers, that you're responding to all of those concerns and making whatever referrals might be necessary as part of that response. And then examples of follow-up actions that you might take in a case study that we'll look at shortly. You could provide activities, so you would check off whichever of the items were relevant to you. You could provide activities and rescreen. You decide how many months down the road. You're going to decide who you're going to share results with. Primary healthcare practitioners should be given results of the ASQ 3 and the ASQ SE. You want to make referrals for any of the other specialties like hearing or vision if those are potentially a concern, or you want to refer to any other community agencies, or you want to refer to early intervention or special education. Or you may decide that no further action would be taken at this time, which, to be really frank with you, would be a big surprise for most young children involved with child protection, and anything else that you might recommend. And just quickly a word on parent report and the research around this. If you are doing this in partnership with a caregiver, there have been numerous studies that have really testified to the value of parent report and how accurate it is in reporting on things like a child's cognitive development, their communication skill, concerns around things like ADHD and gross motor difficulties. And then in terms of qualities of assessment tools that you want to take into consideration, and were certainly looked at for those who might be wondering, why did this tool get selected as opposed to a different tool? And these were the things that were looked at: the normative population that the tool was developed on, the validity, reliability, the cultural sensitivity of the tool, the comprehensiveness of the tool, and the attractiveness to kids, because in some instances you may need to actually do some of these tasks with the kids. And typically children actually love doing the ASQ. A note about culture as you're going through the questionnaires. Food and feeding practices could vary significantly. Even the types of books and writing tools that a child is exposed to, the types of toys a child might be exposed to, and the kinds of just daily activities, sports, etc. a child is exposed to will be influenced by that child's culture. So it's going to be important as you start to think about, what's the plan going to be for this child, you're going to want to think about the culture of the family that the child is currently with. So in summary, the AFQ can really help bridge communication with families. If it's appropriate to do it with a caregiver, it can lead to some very rich conversations. It can definitely help you in making referrals to community agencies. Referral agencies typically are quite happy to see an AFQ result. The score does mean something. Many other professionals do use it, so that score is going to have some meaning for them. Referrals should be based on a variety of things, including the culture of the family, in addition to scores, the child's social history, the child's present situation as well. Developmental issues for this population are very complicated. I can't stress enough that if you've got a child who is showing you that their development is at risk of a delay after completing the Ages and Stages questionnaire, aside from making that referral, wherever that appropriate referral may be, you really want to start looking at what is the caregiver going to start working on today to help support this child's development. But it is complicated. Development is what we have to look at to better understand how trauma, neglect, abuse, maltreatment may have actually impacted an infant who really does not have the language skills to tell you what has happened to them, and then use available resources to make decisions about what steps to take after screening. Depending on the community that you live in, certain services will or will not be available, but look at agencies such as Ontario Early Years Centres, parent literacy programs, children's mental health treatment centers. Healthy Babies, Healthy Children is an option. So really do a good assessment of what are the actual resources that we're going to refer this very young population to so they can get some additional support. So that's the end for the Ages and Stages Questionnaire 3, and we're now going to move on to the Ages and Stages Questionnaire Social Emotional. So this is also can be used with parents or caregivers. What I'm going to do in this section is go over with you the benefits of screening for social emotional development. We're going to look at the SE tool and look at how to score it, look at how to describe the SE cutoff scores, and how to interpret the information in the context of other information that you have gathered about a child. We'll again revisit the importance of communicating the results with sensitivity, discussing the process for referring kids, and talking about appropriate follow-up activities. So what is the AFQSE? It too is a questionnaire that can be completed by a caregiver. Again, if you're using it together with a caregiver, it can often lead to some very good conversation and discussions. It includes a series of questionnaires for children ages 3 months to 5.5 years, and the tool accurately identifies children at risk for a social emotional delay. And just a reminder that we just finished looking at the AFQ3, which primarily focused on the 5 major domains. The AFQSE takes a much deeper dive and looks at social emotional development. So why even do this? A lot of people will be surprised when we talk about the fact that we can actually detect vulnerability or risk for delay in terms of mental health as early as 3 months. And the why is really based on what we now know from the science. So we have a much better understanding about the early indicators of vulnerability for poor mental health. So what are the behaviors that we actually do need to really be quite concerned about when we see them present in a young child. We also know that when children experience poor early mental health, this sets the stage for poor later physical and mental health outcomes. it's a large study called the Adverse Childhood Experience Study that you may want to look up. It was a retrospective study with a very large sample, but what the clinician found was that many people who were suffering from things like cardiovascular disease, diabetes, obesity, depression, involvement with the criminal justice system, involvement with relationships that had quite a bit of violence, etc., that these individuals had experienced a lot of adversity very early in their life. So early experiences actually set the stage for later experiences in life, as well as later outcomes in terms of physical and mental health. And we know that in terms of that vulnerability, if we can recognize it early and actually respond to it early. So, and this is why I keep emphasizing, it's really important that even though you're making that referral to an agency, that you're also thinking about what you're going to give a family to work on while they wait for that referral to happen. Because we know that recognizing early and responding early is more likely to have a positive influence on those long-term outcomes. We also know that when young children experience trauma, neglect, and/or abuse, it affects their development, including their social-emotional development. So it really isn't enough to just look at their physical development. It isn't enough to just sort of eyeball the child and say, well, you know, he looks to be fine. You actually need to be looking beyond what's on the outside. We also know there's a very strong link now supported by numerous research studies that there's this link between early emotional development and later social behavior. We also know that behaviors, even in infancy, signal the need for intervention. We just need to know what behaviors to be looking for. There's also a link between early risk factors, poor outcomes, and violence. And then finally, by third grade, programs for children with antisocial behaviors are mostly ineffective. You know, by that point in time, a lot of wiring has happened in a child's brain. And to unwire and rewire some of those connections can actually be very challenging for a child and very challenging for the people around that child. This image that you have in front of you is a chart, an observational tool that was developed by Mary Rella, who many of you I know will know as an expert around therapeutic access and infant mental health. And I would encourage you to refer back to this, because quite often when we say to people that we want them to observe a young child's development, they're not really sure what they're looking for. And what this chart really helps you to understand is that in addition to what you're doing with the tools such as the ASQ3, you also want to be observing what's happening for infants and toddlers. You want to be looking at the kind of caregiving behaviors that they're experiencing. Are they experiencing caregiving that is sensitive and responsive, or is it harsh and punitive? You want to look at what that attachment relationship looks like. Is it looking like a secure attachment or an insecure attachment? When this child is actually distressed, what does this child do? Does this child seek proximity to his or her caregiver, or does this child actually try to put some distance between himself and the caregiver, looking for autonomy? And then you want to look at their stress response system. So when a child is distressed and dysregulated, you want to be watching to see, what does this child do with the caregiver? Does the caregiver step in and help that child to regulate down and to calm down? Or does the caregiver step in and themselves get dysregulated, and now both caregiver and child are dysregulated together? And we worry about that because, of course, there are really serious implications when children are always dysregulated, always experiencing a toxic stress response in the absence of that responsive, buffering, caregiving relationship. It has some very negative implications in terms of brain development, because toxic stress will actually produce cortisol in higher levels than a baby's brain can manage, and literally bathes the brain in cortisol, which ultimately can kill brain cells. And then finally, we want to look at that child's social emotional development. We want to look at their sense of self, their sense of self-esteem. Is this a child who exudes a feeling of, I am loved and I am worthy of being loved? Or is this a child who has a very negative view of himself within the context of the relationships that he's in? Some of the barriers to actually assessing social emotional development in the past, a lack of screening tools, lack of knowledge, which I would say is still a challenge today. Infant mental health is still largely not well understood. Also the complexity of issues, because quite often when we see an infant experiencing poor mental health, that is happening within the context of a caregiver-child relationship, and it's not unusual for the caregiver to have issues that have gone unresolved or trauma that's not been dealt with themselves, and that will influence how they parent and care for a child. And then the lack of services. So you do a screen, you get a result that says a child is at risk for delay, and then you are met with waiting lists, or in some instances, I know for some communities, just really a lack of services. So that can also present a barrier, because some might say, why bother screening? I don't have anywhere to refer a child to. But in fact, there are things that, once you know there's a delay, start to think about what can you encourage a caregiver to do to really support that child's development. Okay, in terms of developmental framework, just very quickly to give you a bit of an overview. In the first 12 months, so birth to 12 months, the main focus is on attachment. And you're going to see this when you start to do the questions in the questionnaires. It's going to become more and more obvious to you which questions are really getting at those issues related to attachment. They will look at behaviors such as regulation, child's ability to regulate emotion and behavior, recognizable states, a child's attachment, and then a child's communication. Moving on from 12 to 30 months, infants, toddlers are really starting to develop that sense of autonomy. They are differentiating between themselves and others. They're also using pronouns now, and they have a sense of self-control and of rules that they're going to be expected to observe. And then finally, from 30 months on, peers become significantly more important. So we start to see the development of empathy, of gender differences, that understanding, of identification of friends, and interest in other children. I'm going to give you a minute to just review what's on the slide in front of you. When we talk about social emotional development, it's really kind of a big bucket. And what does that really mean in terms of behavior? So the questionnaire that you're going to be using, the ASQ-SE, is looking at the following behaviors across this age group. So self-regulation, a child's ability to comply, a child's ability to communicate, both in terms of verbal, nonverbal communication, the ability to show others how they're feeling, show their affect, and then a child's adaptability, a child's sense of autonomy, the affect that they have or willingness to actually demonstrate their own feelings and empathy for others, and then finally their interaction with people. When they looked at the utility of the program in terms of parent satisfaction, it really does not take long to complete, and this applies to both the ASQ3 and the ASQ-SE. Both of these questionnaires can actually be done within 10 minutes, especially if they're completed by somebody who actually knows the child well. 28% said it took them 10 to 20 minutes, and then there was a very small percentage that took more than 20 minutes. I will say, though, that if you are doing this with a caregiver, it will take longer because there will be some very rich dialogue, some very good discussion that's going to come up as you're working your way through the questions. I see that as a plus, not a minus. I think it's actually a real strength if you can do it with a caregiver. And when asked how easy was it to understand the questions, overwhelmingly the majority felt the questions were actually quite easy to understand. In terms of the appropriateness of questions, next page, for the child's age, again, overwhelmingly people felt the questions were appropriate. Then they were asked to react to a number of statements. The questionnaire helped me think about my child's behavior. More than half of them agreed. Was interesting, was fun to do, didn't tell me much, was a waste of time, and took too long. Okay, so let's skip ahead now and look at features of this particular tool. So there's a number of questionnaires starting at 6 months, going all the way up to 60 months. Now, for the questionnaires earlier on, there are between 19 questions and 33 questions, okay? So obviously for the questionnaires that are dealing with the youngest age group, the 6 to 12-month questionnaires, those are the ones that are going to have closer to 19 questions. Once you're into the 48, 60-month-old kids, you're going to be hitting around 33 questions on a questionnaire. Just like the ASQ3, there is a window in terms of the administration age for the questionnaire. So the 6-month questionnaire is actually useful for a child 3 months to a child 9 months. So I'm going to show you how to look at that, or how to determine which questionnaire to use. And then you don't need to worry for correcting for date of birth or prematurity because that window is so wide. Okay. These questionnaires are also written to a grade 4, grade 5 reading level. Every questionnaire includes open-ended questions related to eating, sleeping, and toileting. All the intervals include the question, is there anything that worries you about your baby or child, and if so, explain. And each interval also includes the question, what things do you enjoy most about your baby or your child? Okay. Now, this is where things get a little bit tricky, and you're going to want to just tag this slide for yourself so that when we get to the scoring exercises, you're going to be able to come back and look at this. So, just like the ASQ3, whoever's filling out the questionnaire has 3 options in terms of responses. They can say most of the time, sometimes, never, or hardly ever. In addition, though, you're going to ask, if it's a negative behavior, you're going to ask them if they're concerned. So if a question has a score, it is marked as most of the time, it's going to get either a 0 or a 10. A sometimes is going to get 5 points. Never or hardly ever could also get a 0 or a 10. And every time the parent says, I'm concerned about this, it actually adds 5 points to that question. And you're probably looking at that now and saying, how can, most of the time and never or hardly both get 0 or 10? Really depends on whether it's a behavior that you want to see, so you actually want them to say most of the time, or if it's a behavior that you don't want to see happen very often. And this will become clearer as you look at the questionnaires. So the first thing to do is to introduce the questionnaire to parents. I've given you some leads if you're not sure how to go about doing it. So this questionnaire asks questions about the child's social emotional growth. Your answers will help us to know what type of information I may need or I should gather that will be of help to you. Some of the questions are not very specific, but based on your feelings or opinions about your child's behavior, that's how I want you to answer. And make sure you let them know that if there's a question looking at a particular behavior they're concerned about, you want them to indicate that it's a concern. Depending on your situation, you may or may do this with them, and I would, for this particular tool, it's actually the next slide. For this particular tool, I would say you should be doing it with the parents, with information at least that you've gathered from caregivers. Some questions on the SC, such as those regarding eating problems, may require clarification for a caregiver. You may just, don't be afraid to rephrase some of the questions if they're not making sense to somebody. Feel that you have the room to do that. Okay? So, scoring. Now, you'll notice when you look at the forms themselves, next to each response, there's a little letter. It could be an X, it could be a V, or it could be a Z. So what's going to become critical for you to understand is that you have to be paying attention to those little letters, because a Z is always going to be worth 0 points. An X is always going to be worth 10 points, and a V is going to be worth 5 points. Now the V is always the column in the middle in terms of responses. The X and the Z, however, could actually switch places. So you've really got to be paying attention not to which column when you're scoring, but what the letter is next to the box. And you're going to have a chance to practice this in the scenarios that we've provided. In terms of omitted items, you can again omit items from the ASQ-SE. You're first going to try and go back and get the answers. See if you can get the caregivers to actually give you an answer. You can omit up to 2 items for the 6 to 18-month-old questionnaires. And then you can omit up to 3 items for the 24-month and up questionnaires, older questionnaires. And again, if you want more information about this, you can take a look at the user's guide. The calculation is very similar. You're going to take your total score on the ASQ-SE. So it's not divided up into domains. It's just one big, long questionnaire. You're going to take all the scored section, you're going to score it, and then you're going to divide that score by the number of questions that were answered. So if the questionnaire you're working on has 33 scored questions, but you were only able to answer 32, you're going to get your total score and divide it by 32. So in the example below, you have a total score of 105 points, and the questionnaire, whoever completed it, answered 30 questions. So you're going to divide 105 by 30, and you're going to add that answer to your original score of 105. So it's 105 plus 3.5 to give you a new score of 108.5. Next, you're going to review the questionnaire with the parent or the caregiver. Really try to emphasize the child's strengths and enforce the positive caregiver-child interactions that you're seeing. Talk about the individual items that were scored at 10 or 15 points. One of the things to remember when you're looking at these tools, the ASQ3 and the ASQ-SE, on the ASQ3, which was the first tool we reviewed, a high score is actually good. A high score is what we're looking for. On the ASQ-SE, a high score is a concern. So when we see an item that has a score of 10 to 15 points, that is definitely something we want to go back to and we want to get some more information about from a caregiver. We want to talk about the open-ended questions that are on every questionnaire and then review the scores and compare them to the cutoffs. And just again, a reminder, these cutoffs are very different from the ASQ3. We want high scores on the ASQ3. High scores are a concern on the ASQ-SE. We're actually looking for low scores. Okay, and then you want to think about referral considerations. Okay, so things to factor in, time and setting, developmental factors, health factors, culture, family, etc. An example to think about, so if you've made a referral to a speech and language therapist, but you've got a little one who's really struggling in terms of language, there's definitely a delay that is in play. You want to see this child interacting with other families, other children, and maybe you're making a suggestion that this particular family could visit the local early years center once or twice a week so the child has a chance to be with other children. But the local early years center is 3 bus rides away, and the family doesn't have a car. That probably isn't going to be a very practical referral that you're making. So you really have to have sensitivity to the family's factors, their culture, what's going to be manageable for them, what's going to actually work in their routine. All of these things have to be taken into account. When you're interpreting the scores after you've completed it, the sometimes issue for some families can be very, very subjective, and really sometimes it's a good landing place when a parent says, you know, or you or yourself, you're feeling, I've seen this child do this occasionally but not consistently, and that's really when you put it in that sometimes column. In terms of validity of the report, if you're doing it with teen parents, parents involved with child protection, which would definitely be all of you, first-time parents or isolated parents, parents who are actively involved with drugs and alcohol, or parents with mental illness, and then for some of you, with some families, many of those things will actually apply. This is not a tool that you can simply give to a caregiver and have them fill out, because we know that the reliability of answers completed by those caregivers is not going to be very strong. If you have a questionable score, so let's say you've done the ASQ-SE and the child actually has a very low score, below the cutoff, which we'd say is a good thing. But you've observed this child and you're still really concerned. You're wondering why the score is as low as it is. What are your options in that kind of a situation? Well, one is to have somebody else redo the ASQ-SE. For instance, if the child is attending a child care program, find out if the child care teacher can possibly complete the SE for you, just to get a different perspective. Gather other information. Observe the child yourself for a longer period of time. Use a professionally administered screening tool. Assess parent-child interactions. Assess the caregiving environment as well. And then in terms of follow-up, a child whose score is below the cutoff, give them some activities, monitor, continue to watch, observe. Maybe in 6 months to 12 months, you're going to redo the questionnaire with the child. If the child's score is close to the cutoff, you're going to want to identify some follow-up things to do to respond to those concerns. You might provide some information, some education and support to the caregivers. You may decide to re-administer the ASQ-SE in a month even, because maybe the child was still settling into a change in his or her circumstances, and you're going to make referrals as appropriate. If the child's score on the ASQ-SE is above the cutoff, you definitely want to make a referral to early intervention services. This could include a feeding clinic. Faith groups are often very helpful. Community groups, YMCA, birth to 3 programs. Many communities have got infant development programs. They may be embedded in public health or other agencies, so you may have to look around, but most communities do have them. parenting groups, and early Head Start programs. You're definitely going to want to refer to a primary health care provider and make that person aware of what you learned from the questionnaire, and you may even need to make a referral for a mental health evaluation. And the thing that I will caution you about in that regards is not all communities have access to professionals who can provide mental health consultation on this young population. So if you're having to do that, you really want to make sure that you have a clinician who has been trained and who has practiced early mental health. Otherwise, we worry about just their familiarity with some of the behaviors, etc. You also want to be looking at caregiver-child interactions, because for those of us who are really immersed in infant mental health, you really can't look at an infant's mental health without looking at the caregiver-child interactions and the contribution of that relationship to a child and their development. So you want to look at things like how the caregiver holds the baby, looks at the baby, talks to the baby, touches the baby, the emotion that they show around the baby. Okay? In terms of infant mental health intervention, if you've got a child who's definitely showing areas of concern in terms of development, you want to make sure you've got a concrete service assessment or assistance plan in place. You want to make sure there's appropriate emotional support for the child, but also for the caregiver, because they are going to need to work hard to support this child's development. In many cases, what is often most helpful is developmental guidance. So as that family is waiting for that more intensive assessment or service, you're really going to want to think about what kind of developmental guidance you might be able to offer this child's family. You're going to look at the early developing relationship for some additional support, and you may want to look into something like infant-parent psychotherapy, which can only be delivered by a trained mental health practitioner. And then, of course, advocating for better services for this child. And now I just want to briefly talk in general about communicating the results to caregivers. I do realize that the AAR is a process that you're using to inform your plan of care, but you also want to make sure that you're sharing the results of these tools with caregivers. So you want to make sure that confidentiality is respected, that they understand the purpose of screening. You don't want to use words like test or pass or fail. Stick to the correct language. We talk about scores being above the cutoff or below the cutoff. Review the questionnaires and explain the areas and the scores. Really try to emphasize the child and family strengths. Provide examples of areas that you might be concerned about, and invite parents to share their observations, or caregivers, foster parents, to also share their observations with you. Make sure you're prepared for the meeting. Take notes. We've administered many AFQs in our office with child protection and families involved with child protection. The response, to be very honest, has been always very positive. Whether it's a biological family, a kin, KIF, or a foster family, generally speaking, they're quite appreciative of having a better understanding of where the child's development is, where the concerns are, and then what they can actually be doing to try to support that child. And then just a word in terms of interagency collaboration. Yep. So, you know, for infants and toddlers, I can't stress enough that if you aren't working with other agencies and you have an infant or toddler who's now shown you on this screening tool that there's a concern about delay, I'm going to really encourage you to get out into the community and find out what services are there. Infants and toddlers who are experiencing delays definitely need agencies working together to support their development. So find out what ages agencies are servicing, what domains they're looking at, what tools they're using, if it's possible to coordinate some of your efforts. Also make sure that you have a relationship with those agencies so that you know, you are all going to get that kid who has a really wow kind of score on one of these tools. And in those instances, you want to be able to pick up the phone, know who you're talking to at the other end, so you can really advocate for that child in terms of being able to access skills, or access services rather, and support. In terms of providing ongoing support to people like yourself, so after you've done the training, the best way to become comfortable with using these questionnaires is to practice them, which we're going to do. Make sure that you also, when you've scored, you know, once you go back and you're actually completing this section of the AAR and you're having to score the tool or the questionnaire, check the score. Have one of your colleagues check the score, especially initially. In our office, if we're helping a team doing this process, we will always go back and check the score, even if we've done the questionnaire ourselves. And then just some cultural considerations. So make sure that you understand that there will be some variations found in things like self-regulation, attachment, feeding, and toileting. So depending on the community and the diversity, the cultural diversity of the community you're working with, you want to become familiar with things like that. You know, look for opportunities to develop cultural awareness, consider families' pre- and post-immigration experiences, use cultural brokers or interpreters. Okay, keep going. And then in terms of other ways to really enhance your understanding of a child, incorporate non-standardized screening methods, interpret results with caution, and make sure that you're really looking at relevant data for a child within their cultural context. Debrief the results with the family or families to together determine the most appropriate follow-up to the screening results. And throughout the process, validate the family's own cultural belief system. Okay? Culturally sensitive questionnaires, questions to gather information from families might include things like, you know, is there a problem that they're worried about? Why might there be a problem? What do they think can be done? What do they think, you know, would be helpful? And who could be helpful to them? Okay? And then in summary, we know screening tools can bridge that communication gap with families. They can also assist in making referrals to community agencies. The strength of making a referral and being able to say, I've completed the ASQ3 and the ASQSE on this child, here are their scores. In some communities, that will be enough to actually put a child closer to the top of a waiting list. So I really encourage you to be sharing those results when and where you can. Any referrals that you make should be based on a variety of considerations, which we've talked about, everything from culture to a family's context to the kinds of resources they do or don't have access to. Recognize that for infants, toddlers, and early preschoolers, social-emotional issues are very complicated and should not be dismissed. What begins as a very small issue in infancy can morph into something quite serious by the time a child enters the school system if it's gone unrecognized and not responded to. And then finally use available resources to make decisions about what steps to take after screening. And then finally, I've given you a list of some websites that may be helpful as you try to incorporate, you know, some of the information that I've shared today, the results of the ASQ, into your plans for a child. Some of these websites may have useful information for you. So at this point, what I'd like you to do is you've also received a number of case studies. You've got a case study for 8-month-old Emma, 10-month-old Adam, and 24-month-old Darcy. You've got a brief paragraph on each of those children and their context. And I know often people will say, well, I don't have enough information. We never have all the information. So you're going to have to make some assumptions, hypothesize about this child's situation, and you're going to actually complete the Ages and Stages Questionnaire 3. To reach me at the Hospital for Sick Kids, you can go onto the Infant Mental Health Promotion website, which is imhpromotion.ca, and our contact information is there. And I'm happy to try and help resolve any problems around scoring or result interpretation that you might have. So thank you very much for joining me, and good